Now we move to Dr. Sabah Jastaneiah, who needs no further introduction. She's one of the pioneers in cornea, and there are very few of them here in the GCC. So, Dr. Sabah, the podium is yours.
Assalamu alaikum, everyone. So, my talk is going to be a little bit lighter than the previous talks. We're going to be talking about a patient who comes in and said, I can't have laser vision correction, and why. Some of these patients will come with the investigation in hand from another clinic saying that these are my investigations and I cannot have, why I can't have the laser correction surgery. So in order to tackle this, we have two kind of factors that we are evaluating. What is the refractive error of the patient who is presenting? Is it myope, hyperope, astigmatism, or presbyopia? And what are you going to do for that patient? Surface ablation or LASIK? Put those two in mind and then move forward. So the primary evaluation we do usually, we have the workup evaluation and we have other factors that we need to consider. I will be talking briefly about each one of those factors, as each one of them is really important to achieve the, to say yes or no for your patient. Now, the first thing I ask my patient when he comes in is, why do you want to have refractive surgery? Most of the patients will give you a valid reason to get rid of glasses. I have a military interview that I need 20/20 vision. Some people would have skin changes around the nose that are really bothering them, fogging around the mask if they're wearing it and they cannot wear contact lenses and so on. But other false justification that you need to be aware of is patients would come and say, I want to stabilize my vision, I want to stop deterioration. Some of them would believe that for themselves, and others would be unfortunately told that by other physicians in order to have the refractive surgery. So you need to know that information. Patients who have partial amblyopia, aiming to improve that bit of correction, you need to be clear with them. And of course, a very important topic, which is getting rid of reading glasses, especially in an ametropic patient. So understand the reason why, because it is very important. And one of the examples is a patient who comes, she's 40 years old, and she wants refractive surgery. She is -2. And when you do the surgery, later on, she would be very upset because she cannot read like she used to be before. After knowing the reason, we would ask the patient, how old are you? It's important in this era to really ask the true age. Especially for women, they would come and you would not really know the true age, so don't guess. Ask. Patients who are younger, we know that we don't do them, and the reason why, because we want a stable refraction. Older patients above 40, again, I have a big question mark. I know that people would do refractive surgery until the 50s, but just remember that we have other permanent alternatives to treat the refractive error. We need to rule out cataract, the type of refractive error. Of course, if it's hyperopia, it's totally different than myopia. And please ask about the occupation of your patient, the hopes that they want to achieve after the correction, and again, tackling the presbyopia condition. So the true age is important. It will tell you if you want to go or if you would say no to that patient. And the refraction itself, stability means in a year. Most patients would come with their glasses. They've been wearing it for a year or two. It's easy to evaluate if it's stable or not. A tricky thing is when a patient who comes with -4, not wearing ever glasses or any correction, you would not go and treat that patient. You would say, go and wear glasses and then reevaluate the patient, because those patients would surprise you that they will not be very happy after the correction. If you have more than 8 diopters, and again, this depends on how your cornea is thick, you would say, I have better alternatives not to destroy the shape of your cornea. Myopia, a patient who comes for a near presbyopic age, how much you would rate? Would you go for a monofocal vision, or that before you do that, you would go for a contact lens trial? And then we'll go to hyperopia. Check for amblyopia. You need a lot of counseling. In my clinic, I spend maybe a few minutes with a patient with myopia, but a lot more with the patients with hyperopia and astigmatism, because I need to talk about a lot of things, including the healing phase, which takes in hyperopia sometimes up to a month to achieve whatever refraction, and we tackle the accommodation issues. And of course, if you have astigmatism more than 2 diopters. The astigmatism is tricky because some people would say that more than 2 is very suspicious, but sometimes you see a patient with -4 or 5 that is a very regular, very normal corneal astigmatism. Tomography, I'm not going to talk much about it already. This subject is tackled, but again, a normal but thin cornea, as Dr. Mazen have mentioned, is not an abnormal cornea. Suspicious cornea, and you need to let your patient know that if this is a suspicious cornea, are you going to follow up a keratoconus protocol and treatment? Are you going to treat or not? And please be aware of the angle kappa when you're treating your hyperopic patients. These are some of the suggested cutoff points for keratoconus, but again, as mentioned, it is variable between studies. This is a patient with high astigmatism, and sometimes in astigmatism, even the optometry would tell you that I have a little bit of scissoring, but it's not the typical scissoring of keratoconus. You need to know how to read your topography very well so you could identify those patients. Now, I have keratoconus, a real keratoconus patient who would come. I am a very shy person when it comes to keratoconus. I usually don't go ahead and treat and don't give a lot of promising, but we know that we can correct some of it if we're following a certain protocol. You need to make the patient understand why you're doing it and why not you are doing it. Me, myself, I don't combine cross-linking with any refractive correction. Scotopic pupil, to make it short, the pupil is significant, but it depends on how it is measured. Most of the studies have found that the average pupil size is around 6 millimeters. Of course, it affects the night driving, and studies have been controversial in this issue. But again, it is very important to mention that and address the pupil size when you are doing refractive surgery. Dry eye disease, if you're doing PRK, it's different than you're doing LASIK. Most of the time, if you have a patient fit for both, I would go for PRK if that patient is having significant dryness. Ask about medications used, ask about systemic disease, like any disease that would affect the eye condition, the dry eye condition. What about pregnancy? Of course, we all know that it's a no. Refractive changes happen during pregnancy. Some of them are transient, some of them are not. This continues while lactating until weaning off. Topical medications can affect the embryo. If we're talking about PRED40 antibiotics, they have a safety profile that we need to follow. In addition, pregnant women can go through hypertension, diabetes, that would again affect your refraction and refractive outcome. Other considerations that I would consider a very important consideration: patients with significant ocular surface disease, blepharitis, specifically if you're doing LASIK, history of herpetic eye disease. I'm sure that many of us won't ask about that, but we really need to ask about it. Glaucoma, this is important for post-treatment for the measurement of intraocular pressure, and prior to that for the evaluation. Ask about autoimmune disease, and it's a controversy about one-eyed patient. Absolutely, if a patient comes wearing contact lenses, harming themselves, and they're one-eyed patient, I would go ahead and do the refractive surgery if they're fit for it. But again, wearing glasses is protective by itself for those patients. Thank you very much for listening.
Thank you very much, Dr. Sabah Jastaneiah. That was a very nice overview